Good afternoon, everyone. My name is Bill Puppard from Frederick Medical College of Wisconsin. Welcome and thank you for being here. This session is designed to engage pharmacy students, technicians, and pharmacists as we explore an emerging and important area of patient care, nociplastic pain. By the end of today's session, you'll be able to describe the mechanisms and most common conditions associated with nociplastic pain, identify guideline-directed therapies for managing nociplastic pain symptoms, and evaluate a patient case to develop a comprehensive pain management plan. Please join me in welcoming Dr. Diane Johnson, a clinical pharmacist practitioner specializing in pain management and residency program director for the PGY2 Pain Management and Palliative Care Pharmacy Residency at the William S. Middleton Memorial VA Hospital. Dr. Johnson earned her PharmD from the University of Wisconsin and has extensive experience working in chronic pain and palliative care clinics. She's also a clinical instructor at UW School of Pharmacy, mentoring students and residents, and serves on several VA committees focused on pain and opioid safety. Outside of work, she enjoys spending time outdoors, especially taking walks during her lunch breaks. Dr. Molly Scheuer is a pain clinical pharmacist practitioner and PGY1 pharmacy residency program coordinator at the Toma VA Medical Center. Dr. Scheuer earned her PharmD from South Dakota State University and completed a PGY1 and PGY2 residencies with a focus on pain management at the William S. Middleton Memorial Veteran Hospital. Since 2018, she has developed a chronic pain practice at the Toma VA, including prescribing controlled substances such as buprenorphine. She also teaches at the Medical College of Wisconsin and precepts pharmacy students and residents. Dr. Scheuer is active in opioid safety and pain management committees and provides battlefield acupuncture as part of the VA Whole Health Program with interest in pain management, mentoring, and motivational interviewing. You can find full bios and additional information about each speaker in the conference app. Please join me in welcoming them.
All right. So, just a minute. Okay. All right. Thanks for joining us, everybody. As we were talking to Bill earlier, this is the extent of Molly's and my knowledge about this. So no tough questions. Just kidding. We love them. We love tough questions. Disclosures, Molly and I unfortunately have none. And just as a reminder, any opinions we have are ours alone, not those of the federal government. Bill went through these. I'm going to introduce you to our patient case. This woman will be with us for the next hour. This is AB, 61-year-old female who presents after several years of not receiving regular health care. She describes generalized body pain in many places, including neck, back, shoulders, forearms, hips, calves. She's had the symptoms since the mid-90s, but more debilitating in the past year. She's unable to get out of bed for more than a few hours each day, but still never feels rested. She has difficulty focusing on tasks like reading and is tearful during our visit when discussing how her symptoms have stopped her from visiting her adult children who live out of state because long car rides are too difficult. She describes little interest in pleasure in activities, hobbies she used to enjoy, like swimming and scrapbooking. What is nociplastic pain? Has anybody heard of this term, nociplastic pain? Okay. All right, we got a few hands up. Excellent. I'm really excited you're all here for this journey. Quick definition from the IASP. This is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptors or evidence for disease or lesion of the somatosensory system causing the pain. All right, no one left. So we still got you. So we're going to dig into this and what this means and how we can apply it in what you see. So like, what do we see of this? So a lot of big words in there. I think if you break it up into little pieces, it'll start to make more sense. So hang in there. We've got three main types of pain. Everybody has heard of the nociceptive pain. This is, I hurt. I broke my arm. I hurt. Cancer pain, arthritis pain. Humans are all familiar with nociceptive pain. The other most common pain type that we've all heard of is neuropathic pain. Our patients will describe lightning, shooting, burning, tingling, diabetic peripheral neuropathy pain, postherpetic neuralgia, for example. And then our third bucket is the nociplastic pain. And we've listed a couple of the main examples on this slide, and we'll continue to dive into these throughout our presentation. This term was first described about 10 years ago, back in 2016. So again, here we see there's no clear evidence of tissue damage or evidence of disease. So that's the big distinction here. So we've got this ICD-11 code for primary pain. So pain is the problem, not the result. If you think of osteoarthritis, some people have pain. So the symptom is I feel pain due to my osteoarthritis. Not everybody has pain, for example. Whereas with the nociplastic pain, it's not because of this disease I have pain. It's just I have pain. And so this is due to the altered pain signaling within the nervous system. We can't pull up an x ray or an MRI or a CT scan and see why it hurts. I think this is one of the most frustrating aspects for all of us. Patients, I always give this example. Before I was in the medical field, I thought you went to the doctor and they fixed you. But now we know that's not always the case. So this can be really hard for people when like I hurt so bad. Why is nobody's believing me because there's nothing on this imaging and we can't tell why. So what are the symptoms when you start to suspect nociplastic pain? Pain that is disproportionate to pathophysiology. So I just went and told you that there is no pathophysiology. Well, people hurt, people have osteoarthritis and nociplastic pain. But why does it hurt so much more than it does in somebody else? So it's disproportionate to something else that's going on. It's often diffuse, widespread in distribution. If you see somebody drawing out a pain diagram with the nociplastic pain, they just like circle the whole body. It can be unpredictable, ebb and flow with time. You have good days and bad days, good times and bad times, stressful events that make the pain worse, or good times when you may not have many symptoms at all. It's often accompanied by other symptoms: fatigue, low mood, sleep difficulties, memory concerns, hypersensitive to stimuli. This is a big one. As Molly will get into, most of the medications we use have side effects, which are amplified by this altered pain signaling process. And then lack of benefit from traditional analgesics. And by this, we mean Tylenol, ibuprofen, opioids. They don't seem to work. So who's at risk for developing or having a nociplastic syndrome? Adverse or traumatic childhood events. So there's so much that we know but don't know about our central nervous system. And what experiences we've had that lead us to this point can affect how signals process through our central nervous system. We do see genetic variants. If you have a first degree relative with fibromyalgia, you're more likely to also develop fibromyalgia. More common in the female sex, and those with socioeconomical deprivation might not have access to the same resources as someone else. Physical inactivity, obesity, baseline sleep disturbances can put you at higher risk. Presence of ongoing pain. This one's sad. Well, this is kind of a sad topic, but pain begets pain. And so your nervous system has those continuous inputs that can then make the pain worse with time. This is the list. I know you've all seen most of these diagnoses before, interacted with them. We list fibromyalgia first because that's the one that we have the most information on. We do have guidelines. It's probably the most studied, the most well-known of our nociplastic syndromes. Irritable bowel syndrome. Have you ever wondered why nortriptyline works for irritable bowel syndrome? Honestly, until I learned more about nociplastic pain, now I'm like, this all makes sense to me. Same with tension headache. Why do we use these same medications that we use for fibromyalgia for these other disease states? Because it's all going through the central nervous system. TMJ disorder. Again, patients will search for the find it, fix it. They'll go see the dentist and they'll go see all these people, and really you need to look at the whole central nervous system. Pelvic pain, bladder pain syndrome, chronic low back pain. This one's tricky because this is almost where the pain begets pain syndrome, where you've got low back pain and then it just morphs and becomes this whole beast all on its own. So there's usually that central component with chronic low back pain. Some newer ones that I've added on here would be opioid-induced hyperalgesia. So this is a phenomenon where we see when you're on opioids for a long period of time or higher doses, people start to feel worse. They develop a lot of these symptoms, like we're talking about depression, fatigue, little interest in activity, pain feels worse. Very similar. Long COVID. If anybody has had patients that have had long COVID, again, a lot of these same features that we're seeing. You could also maybe think of Lyme's disease. So there's a lot that we're coming to understand more as a disease of the central nervous system. Even though fibromyalgia only affects 2 to 8% of the general population, it is the one that we have the most evidence on and most guidelines. You can also see pelvic pain and irritable bowel syndrome as pretty common in the general population. So that's why it's important. And I'm so glad you guys are all here learning on learning how to manage this and talk to our patients and understand what we're going through. There was a validated screening tool back in 2013 for central sensitization inventory. I would say central sensitization was the term we were using before nociplastic pain. Um, and then the widespread pain index and symptom severity scores. The most common one is the one we use in our practice for fibromyalgia. It's a certain number of body parts and then a certain number of other symptoms. You add up the total and you reach a certain number, you're diagnosed with fibromyalgia. And then the fibromyalgia survey criteria is another one. I'm just less familiar with that one personally, but all ways that you can diagnose fibro. So what is central sensitization? It's an amplification of the nociceptive transmission in spinal and supraspinal pain pathways. And so if you remember the nervous system, we have the peripheral nervous system, which feed into the central nervous system, which includes the spinal cord, dorsal ganglion roots, and up to the brain. So we're talking about that central nervous system pathway. Imbalance of glutamate and GABA neurotransmitters. So these are the ones that balance out. In normal functioning, you've got the excitatory neurotransmitters that give you what you need to get through a stressful event. And then the GABA ones come in and calm everything and put us back at our baseline, and they balance each other out. With central sensitization, you've got usually too much glutamate action and not enough GABA. So you've got that constant excitement. And then upregulation of certain receptors, a lot of the opioid receptors, which is what we'll get into the next few slides as well. This might look familiar if anybody remembers how depression has some of these monoamine imbalances, decreased serotonin, norepinephrine, and dopamine. So this makes sense as to why we see a lot of similar features with depression and nociplastic pain. The neuroimmune interactions. So again, I talked about the neurotransmitters. Similarly with the anti-inflammatory and pro-inflammatory cytokines within the central nervous system. So you've got the pro-inflammatory, they're recruiting all of these cytokines to ramp things up. We're going to activate the glial cells via the toll-like receptor 4. And so you've got a lot of excitation going on within the central nervous system. This is the mu-opioid receptors. You got the disruption in the reward pathway. Excuse me. High concentrations of endogenous opioids within the cerebral spinal fluid. So endogenous opioids, endorphins, the happy chemicals that are normal. And when we can activate them, they act on our opioid receptors and we get that good feeling. What we see with nociplastic pain is a strong reduction in those receptors within the nervous system due to downregulation. And so you have the high concentrations with not enough receptors. And then you see this persistent pain that creates this continuous demand. And so then The receptors that are there, because they're so used to being activated all the time, just don't respond like we want them to. We've got the top down and bottom up. So top down would be the descending pathways from the brain down to the peripheral nervous system. And on that side, we talk about what impacts this is genetics, our prior experiences. I mentioned the trauma, adverse childhood events, our expectations. I shouldn't be feeling this way. And then the maladaptive thoughts that come along with that, the emotion, the mood. Pain or symptoms do not resolve when the nociceptive input is removed. So when whatever is causing the symptom, if there was an injury, the injury has healed. Why does it still hurt? And so this would be primary fibromyalgia when the pattern is the central nervous system down to the periphery. On the other side, we have secondary fibromyalgia, which has a lot of the pain begetting pain, and so the constant bombardment of the signals. Dr. Claw gave a talk a year or two ago, and I really liked his analogy with the electric guitar. And I'll use this when I talk to patients. It can help explain the phenomenon. So you've got the electric guitar, you strum the strings, it goes through the amplifier to the speakers, and that's how we all enjoy it. If you're strumming the strings, but the amplifier is not working right, what are we going to hear? It won't be correct. It could be maybe it's too loud or maybe the pitch is off. It could be fuzzy, but is that processing? So it's not a problem with the guitar player or our bodies, our peripheral. It's that signaling pathway in between. The other thing he talked about, which have really come to embrace, is fibromyalgia ness. So this was a term coined originally by Frederick Wolf, whereas fibromyalgia or nociplastic symptoms occur on a continuum. You don't want to think about it, it's either here or not, present or absent. You can have a degree of this nociplasticness or fibromyalgia among different people and among one person's lifetime. So we talked about how different things can affect your response. Like our stress can impact how our pain is from a day-to-day basis. We've all felt that in our lives. We feel worse, maybe when we're stressed or not sleeping well. So if you take a fibromyalgia survey at that period, you could score positive, but a different time in your life when maybe things are going differently, you might score negative. So do you still have fibromyalgia? Did it resolve? Did it cure? So thinking about it more, um, of what is like long term, not just necessarily present or absent. And I think to a degree, everybody has different ways that their body processes things. It's when does it become pathologic in that moment? So we talked a lot about what we're dealing with, and there's certainly a lot going on. But this is the maybe the more fun part. We get to talk about how we can help people when they're experiencing this. So the first is effective patient and provider communication and being able to explain the pain process. So what we hope is that maybe you've picked up on a couple of things throughout this presentation that you can go back to your patients and help them to understand, why do they hurt when somebody else doesn't? Why does it hurt so much more for me? Validating their symptoms. I don't know that I should say this, but patients will say, "Oh, so you think it's all in my head?" It's like, well, if I cut off your head, you wouldn't have pain. You can't say that to everybody. I would caution you should really have a rapport with your patient before that. But it's true because that's where we're processing things and we're experiencing it. So yes, it's in your head. It's also in your spine. The other thing I think of, Molly, is that Harry Potter movie where he's at the train station and then the Dumbledore, who's dead, like comes and Harry's like, "So is this all in my head?" It's like, well, yes, but that doesn't mean it's not real. So just another way to help patients explain and understand, I understand what you're feeling, even though I can't feel it for you. I can't see it on an image. I can't wave a magic wand and make you feel better or give you Tylenol and you'll be okay. But I understand that you hurt and I understand how impactful this is on your life. And we're going to work together to create a whole health, whole management plan and approach. So you really want to empower this individual to take an active role in their management. This isn't something that we can fix um, we can help people manage it and want to improve things moving forward. It's also important to manage the co-occurring symptoms. So, depression, sleep disturbances are a natural part of nociplastic pain or fibromyalgia, but they should also be treated accordingly with the right resources that's available to the patient for those disease states. Goal setting, we do that with all of our pain diseases. Very important with nociplastic pain. We understand where the patient is, where do they want to be, um, what activities do they need to get back to, and what's realistic. Again, keeping in mind we can't fix everything. We're not going to get to a pain score of 0, but we can get you back to a functional routine. And the non-pharmacological management is our mainstay of treatment. So if you remember our patient AB, so again, generalized pain, difficulty focusing, never feels rested, little interest in activities. What symptoms does she report that might make you suspicious for fibromyalgia? Did everybody get all of the above? Great. What you can't see is it says treatment recommendations in EULAR, and that's the European guidelines for fibromyalgia. Keep in mind these were last updated in 2016. So I know there are studies that were published between 2016 and now. And if Molly and I had access to our speaker's notes, we would be much better at speaking about those. So bear with us. Um, the importance part here highlighted in these guidelines are prompt diagnosis, comprehensive assessment, non-pharm modalities, patient information, and then a gradual approach. People wait for months to come in and see us in the pain clinic, and they say, what is your goal for today? And they're like, to take away my pain. It's like, oh, well, you've had pain for 20 years. Like, we're not going to be able to do that in our 55 minutes remaining here. So it's this developing the relationship and the plan. This is a EULAR guideline, um, non-pharmacological management. We've got strong evidence for aerobic and strengthening exercises, weak evidence for the rest, which we'll get into. 20, there were at the time, there were 20 systematic reviews, over 2,000 patients, that both aerobic and resistance training improve pain and physical function. I always like to ask my learners, do you know what the best exercise for chronic pain is? The one that your patient will do. So it's what they have access to. A lot of patients love swimming. It takes gravity almost out of the picture, or water, walking, water exercises. But pool memberships are very expensive, not often covered by insurance. So you think, okay, well, how about going for a walk? Not all patients live in neighborhoods where they can go outside and walk around. Some people are limited by other physical um, or health concerns where they can't do a lot of walking or get outside. Maybe they might not have access to the internet to watch a Tai Chi video. And so it's working with your patient. Maybe if there's a health coach or some way we can get involved and figure out what we can do that our patient has access to and enjoys doing and will continue to do. I think CBT is recommended for everybody for everything, specifically for pain. It can help understand pain's connection to the emotional, psychological, and social factors. Here we're talking about the suffering. So you've got pain, which is like, I physically feel pain, and then the suffering is the mental anguish. Patients will use that term. They'll say, I'm just suffering here. I'm like, well, I want to talk about that. I want to talk about the suffering, and what the suffering is your relationship to the pain. And so this CBT can help do that with cognitive restructuring, behavioral activation, stress management, problem solving skills, functional goal setting. It's a lot of work. Patients really need to be actively engaged. You get homework, but it is a limited number of sessions. It's 6 to 8 weeks. And so I think most people, if they have access to this, can understand that it's a time limit, it's a class, I'm going to learn a lot. Not I'm going to go sit and talk to somebody for an hour about how I'm feeling, which also probably very helpful and needed. But if that's not something they're interested in doing, this might be a good way to help them understand that connection between the mind and the body. Acupuncture originated in China over 2,000 years ago. The elements are the qi, which is energy flow, yin and the yang, the positive and negative, and then the 5 elements. The exact mechanism of action is not well known. We just know that people have been doing it for this long. It works for some people. I I do like to tell my patients that you have to believe it will work. If you go in thinking it's hooey, it probably won't work. The theory is that the chi or the energy, it's everywhere, but it flows throughout their body in meridians. And when there is a blockage in our chi, that's when we feel a symptom. And so the acupuncturist will identify where that blockage is, and that's what they target to get the energy flowing again. So that's why I say you have to believe in it. You have to believe in these energies. And um, we had a feng shui consultation in our house, and so like I believe in energy now. We made some changes. I'm like, my energy is flowing much better. Uh, I do think there is a role for it, especially if what we're doing with traditional with our medical approach isn't getting us where we needed to be. Let's try something else. I also want to try this one out. I haven't yet. Hydrotherapy or spa therapy. It is where you're lying in like a zero grad, like a saltwater pool where you're just floating there, so you don't really know like what way is up. They've been doing this also for a really long time in ancient cultures. It can promote muscle relaxation, improve emotional state. There's some moderate impact on pain, healthcare quality of life. Not significant, but I'd sign up for it if it was recommended by my doctor. So, meditative movement, qigong, yoga, tai chi. Again, this goes back to our energy, and it's listening to your body. There's movement, which is great, but then there's mindful movement or meditative movement, which is where you're really listening to your body. And people who are good at it then incorporate these movements into their daily routine. So instead of standing at the sink doing dishes bent over and my back starts to hurt, I can listen to my body, get into my horse stance, and support my spine. And I'm going to have a lot more stamina to do an activity. I'm also going to listen to my body. And when my body needs a break, I will take it before it gets too late. So there's a lot of evidence, and Tai Chi is the one that I recommend the most for my patients. Mindful based stress reduction. Unfortunately, low quality of evidence, but it does see short term improvement in quality of life. I think this is just another great life skill that anybody who's access to one of these classes, it would be great to incorporate into our daily routine. It can help improve coping, which can reduce the suffering. We are one body, everything goes through our central nervous system. If you are dealing with a chronic pain or nociplastic syndrome and you have a stressful event, what's going to happen? Something's going to give. You have to put your energy now instead of managing your just day-to-day life with this chronic pain to managing the stressful event. So then your pain will be worse in response. And so it's helping us to understand that. And you have to get good at these. You have to practice them. You have to understand them. All of coping skills we have to get good at, because when you need them is not the time to practice. It's like, yeah, I don't want to practice my drives on the golf course. I do that elsewhere. So then when I'm in the moment, I know how to employ them. Multi-component therapies is putting all of this together. This is great in theory. And when I think about this, I'm like, well, I work full time. I'm a mom. I want to do other things. When am I going to do these? And so again, it's working with your patient to see what makes the most sense, which of these pieces they're going to be able to do and enjoy and understand the importance of. Not everybody can do everything at once, even though I wish we could. So what's not recommended in this guideline? Biofeedback, hypnotherapy, and massage. But if this is what my patient wants to do or want to learn more about, I'm going to send them to try these. If we can get them engaged in something and it clicks for something, they're going to come back and they're going to want to keep learning more and try new things. Strong against chiropractic care due to safety concerns. I do get a little bit nervous when people tell me they're going to a chiropractor. We want that chiropractor to know what the anatomy is of the body before doing an adjustment and be involved in this holistic healthcare that chiropractic, acupuncture, medicines can all be part of the plan, but there has to be the active involvement as well. All right. So our patient AB has been diagnosed with fibromyalgia. She wants to avoid medications. And so which treatments do we want to recommend? Did everybody get A and D? Excellent. All right.
I'm a little shorter. So, we're all pharmacists, pharmacy technicians here, right? Pharmacist-minded folks, and we haven't talked about a medication yet. So you're probably wondering, well, where's the medication role here? I think, especially in pain management, if you're familiar with pain management and what we've already been talking about is it's a multimodal approach. So yes, medications are part of the picture, but they are not the only thing. And honestly, for this type of pain, like Diane mentioned, actually the non-medication things are the basis and really the requirements for everybody as much as we can. But my role is to be able to talk about what do we use if we're going to talk about medications. So looking back at the EULAR guidelines that Diane mentioned earlier, this is what's recommended for medication considerations. Interestingly, you can see all of these are week 4 recommendations. And the most recent update was in 2016. We did leave pramipexole on here because it was recommended in the 2008 guideline, and we'll talk a little bit about some evidence or where that can play a role. So the fact that these are all week 4 recommendations helps us to maybe support or understand why they're not the only recommendation for this type of pain treatment. When you're thinking about medications, especially if we're talking fibromyalgia, that's what we're going to focus on for the medications and for the recommendations here, since it's the most that we know the most about, like Diane mentioned. You can think about kind of a couple of buckets. What would I want to use kind of first? If a patient primarily has pain concerns with not so much of the other nociplastic pain diagnosis symptoms or side effects that can come from it, you might want to think about things like duloxetine, pregabalin, or tramadol. On the other hand, if patients have fairly significant sleep disturbances, some stronger medications in that bucket might be things like amitriptyline, cyclobenzaprine, or pregabalin as well. We're going to look at each of the medications kind of in some different buckets here. So first, we're going to look at the antidepressant group. The first group that's recommended or talked about in the guidelines are tricyclic antidepressants, or TCAs. The guideline specifically talks about amitriptyline. That's what has the most studied evidence for. How do TCAs work? Well, they increase the concentration of serotonin and or, depending on the one we're talking about or the dose, norepinephrine in the central nervous system. And you're going to notice that the medications we're using are going to help try to get at the root or go back to what Diane was talking about, why nociplastic pain is a syndrome and how it behaves and what it looks like. So TCAs help to bring back that balance in the signaling pathways so that we can have improvement in symptoms. TCAs and most of these medications we're going to talk about obviously have many indications. They can be used for depression, but typically in fibromyalgia, we use them at lower doses, less than 100 milligrams in a lot of cases. The guidelines do talk about amitriptyline, but interestingly, we know that there are more TCAs available. The secondary amine TCAs like nortriptyline can actually potentially be better tolerated and focus more on the norepinephrine aspects versus serotonin. So theoretically, these might just be a better option for a lot of patients just because we know TCAs have a lot of side effects. They're on the Beers criteria list, and Diane and I working in the VA, we see a lot of elderly patients that fall into that greater than 65 age range. And so TCAs tend to be less ideal for the fact that they have those anticholinergic, sedating, and orthostatic hypotension type symptoms. Not that nortriptyline takes those symptoms away, but they just seem to be better tolerated than others. The other thing to think about is that TCAs can be lethal in overdose as well. So trying to take into account patients' current mental health status as well, and maybe limiting quantities that people are prescribed depending on their current status. The next antidepressant group to look at would be the serotonin norepinephrine reuptake inhibitors, or SNRIs. The guideline specifically talks about duloxetine. This one is one of the FDA-approved medications for fibromyalgia. And similar to the TCAs, they work on serotonin and norepinephrine reuptake and some weak inhibition of the dopamine reuptake as well. Again, there's lots of indications for SNRIs, and so different doses based on the indication. Typically for pain and nociplastic pain symptoms, we like to try to get to at least a dose of 60 milligrams per day because that's that therapeutic dose. But really, we see benefit even at smaller doses in some patients as well. Another FDA-approved SNRI is milnacipran. This one is actually only FDA approved for fibromyalgia in the United States. It does have other indications of approval in other countries, but here in the United States, it's just for the fibromyalgia diagnosis. Again, similar norepinephrine and serotonin reuptake impact. And for dosing, milnacipran is interesting. It has a pretty kind of stepwise titration schedule. And so milnacipran does have some nice laid out titration packs that can be prescribed to help aid in that titration process for patients. We try to get to doses of 100 to 200 milligrams per day. Obviously, duloxetine and milnacipran are not the only SNRIs available. You might be thinking, well, what about things like venlafaxine, desvenlafaxine, levomilnacipran? These, of course, are all SNRIs as well. They all have that same mechanism that I was sharing with the other two SNRIs that we looked at more specifically. These just are not mentioned in the EULAR guidelines specifically, but knowing that these do have similar mechanisms of action and ways that they obviously could be beneficial, we could assume or translate to these being also beneficial as well. And do we see them being used? Yes, I prescribe especially things like venlafaxine in my practice all the time. Specifically for fibromyalgia and nociplastic pain symptoms, there's just few studies, small sample sizes, lack of placebo-controlled trials without blinding. So having that robustness of evidence is just not there. One of the other things, unfortunately, we don't have our speaker's notes, as Diane said. So I wish I had them because each of these medications, as we go along, do obviously have studies and evidence for their approval originally on the market. And when you look at medication use in pain, most of the studies show benefit on pain, but usually it's like 30% or less improvement. And some of the medications will have some benefit on the other factors like fatigue or sleep or quality of life, but those are not usually as robust as the potential pain benefit. And the pain benefit is like a 30% reduction. So again, I think echoes, and I stress this to the patients I talk with as well, that yes, medications can be helpful, but they're not the only thing. I don't have one medication that I can think of that we are going to prescribe and it's going to take your pain to zero based on the evidence and the studies that we have. Do patients take medications and have wonderful results? And I see some pretty significant improvements in patients. Definitely, but that's not everyone. And I think the grand majority of the time it's, well, it helped a little bit and now I've got side effects, or yeah, I'm tolerating it, but it's kind of helpful, but not great. And again, I think would just echo the need and the ability to think about the whole person and pull in those other things that Diane was already mentioning. So those are the antidepressants that are mentioned and we can take a little bit more look at. The next group are anticonvulsants. Here we look at first pregabalin. Again, this one is one of the FDA-approved medications for fibromyalgia. This medication, though, does come with some other monitoring and risks because it is a Schedule V controlled substance. So that limits potential access for some patients and obviously some extra regulations and rules and steps that they have to do to be able to continue to be prescribed or to get prescribed this medication. Gabapentinoids are anticonvulsants, so pregabalin specifically here binds in the CNS to inhibit those excitatory neurotransmitters. Diane was talking about how in nociplastic pain, we have such an over uh, balance and higher balance of those excitatory neurotransmitters like glutamate, serotonin, dopamine, substance P, and the like. So I usually explain to my patients, similar to what Diane was saying with that guitar analogy, but also helpful to kind of think about, it's almost like we have the gas pedal on with all these excitatory neurotransmitters. The medication's role is to try to put the brakes on that a bit. They do a good job at that, but they also put the brakes on like everything. They're not selective. So that's where you can get the side effects of sedation, constipation, mental cloudiness or confusion. And unfortunately, like was stated earlier too, patients who have nociplastic pain sometimes already have those symptoms to begin with. And so now if we're taking a medication that just enhances that or creates more of that, that's not always ideal. For pregabalin, typically it's titrated up to doses of about 450 milligrams per day. Usually I use it twice a day, but it can be even dosed 3 times a day. The other anticonvulsant here in this group is gabapentin. It is an older medication, does not have the specific FDA approval for fibromyalgia, but again, we can use it, has similar mechanism of action with modulating those excitatory neurotransmitters. This one might be a little bit nicer for some folks from potential access concerns because it is not a federally controlled substance. However, many states have started to create it to be a controlled substance or have added some additional monitoring requirements. So specifically in our state, Wisconsin, it is not a controlled substance, but it is considered a substance of concern. So it is one that needs to be reported to the PDMP and check the PDMP prior to prescribing or dispensing. And I think that potentially different practice sites have different policies on other requirements. For example, my site suggests that it also may be useful to get a urine drug screen if you're going to be prescribing this medication. That's a requirement for all controlled substances. It's a suggestion for this one since it has similar crossover potential. Lots of dosing for gabapentin. I see wide ranges from very low doses all the way up to very high doses, closer to 3,600 milligrams a day. The most important part here is to try to start at a dose that patients can tolerate and titrate up. Typically, a therapeutic dose is at least 1,800 milligrams a day if patients can tolerate it. One of the big things I think with gabapentin too is just the pill burden that sometimes can come from it and medication adherence problems that come with that, of course. So while it can be very helpful and it's widely available, it has its own challenges, of course. So some other medications that fall on the guidelines for consideration, one would be cyclobenzaprine. This medication is related to TCAs, so it has a pharmacological similarities there. Because of that, it's also similar in its side effect potential. So you think about all of the things that can come from TCAs and worry about using it in the elderly. That's the same here with cyclobenzaprine. This muscle relaxant is centrally acting, so it tries to work on the tonic somatic motor activity, impacting again the excitatory neurotransmitters. Usually in fibromyalgia, this is used at a low dose and usually starts to be used at just once a day at bedtime to help more with, again, like I was mentioning earlier, the sleep type benefits and concerns that patients might have. However, it can be dosed throughout the day. And obviously, as we said earlier, patients don't just have one type of pain. So can we see folks that have nociplastic pain that also has muscle spasms or have other concerns that we want to use this medication for? Definitely. And we might see it used throughout the day as well. Tramadol is mentioned in the guidelines as well. Again, this one is a controlled substance also, so similar to pregabalin considerations. This has those same monitoring concerns to think about. Tramadol is a unique medication, as we're all probably familiar with, in that it has both mu-opioid receptor binding as well as impact on things like the norepinephrine and serotonin. So I kind of explain it to patients like it's an opioid SNRI combination drug. It's kind of a cool unicorn, I guess, if you will, but because of that, it comes with other concerns and side effects and drug interactions. And while it sounds like a safer medication, it tends to be not as a safe medication as we would think. It is less potent than other opioids, though, but it does still have those same opioid risks, right? Like the side effects, the risk for tolerance and addiction, and other concerns that come with it. So if tramadol is mentioned in the guidelines, what about other opioids for fibromyalgia? The EULAR guidelines actually have a strong against recommendation for, quote, strong opioids. So everything other than tramadol, essentially. Why is this? That's because there is really a lack of evidence for efficacy in fibromyalgia, very high risk for side effects, the potential for abuse, and there is evidence to show that long-term use of opioids can make fibromyalgia pain worse. Really working on that upregulation of the endogenous opioid system and opioid-induced hyperalgesia, and that's already present with fibromyalgia and nociplastic pain, and now the medication is just playing into that and making it worse. Pramipexole, like I mentioned earlier, was not mentioned in the most recent EULAR guideline, but it is recommended in the 2008 guideline. And this is one that does have some evidence for both pain, function, and fatigue benefit, though it has a high burden for side effects. So you got to think about that with the folks that we're working with. It's a dopamine agonist, so stimulates dopamine activity on the nerves in the brain and gets to some of those underlying reasons for how nociplastic pain works. The last medication we'll just touch on briefly is naltrexone. This one is not mentioned in the EULAR guidelines, but it is something that is talked about a lot in the pain world, and specifically when we're talking about nociplastic pain. This might be a newer thought or consideration for a lot of you, that we know naltrexone is an opioid antagonist. We use it for things like opioid use disorder, for example, or alcohol use disorder, and it's FDA approved for those reasons. But interestingly, naltrexone actually has a paradoxical analgesic effect at low doses, basically meaning doses of like 9 milligrams or less. This is off-label, and you also might be thinking, well, how do we get a dose of 9 milligrams per day? Because naltrexone comes in a lot higher doses. So a challenge with this type of prescribing or dosing would be it has to be compounded. So it's not easy to be able to access or to use. How does low-dose naltrexone work, though, for pain, specifically nociplastic pain? It has a couple of reasons of why it could be beneficial or how it works. One is the work on the toll-like receptor 4 antagonism. So by doing this, it inhibits those pro-inflammatory cytokines and decreases systemic and neurogenic inflammation. So if you decrease inflammation and the inflammatory cytokines, we can improve pain symptoms. It also is working on transient opioid receptor blockade. So again, Diane was mentioning those endogenous opioids being high and out of balance. And so having the benefit of increasing endorphins and enkephalins, upregulation of our receptors we have in our body so that there's more there, more receptors there, we can use them more, we can have pain relief. All right, so that covers the medications that are talked about in the guidelines and that we wanted to mention to you all. Here's a knowledge check. So which of the following are not guideline recommended medications from the EULAR guidelines? So B and E, right? The others are specifically mentioned. Could these all be used? Absolutely, but those ones wouldn't be actually specifically mentioned in the guidelines. And going back to the patient that we saw earlier, if we're looking at maybe something to help her target her sleep concerns, which of the following would you consider starting for our patient? So lorazepam, cyclobenzaprine, amitriptyline, oxycodone, or duloxetine. So this is a select all that apply. So there's probably the multiple answers here. The ones that Diane and I were thinking about were cyclobenzaprine and amitriptyline, just because that's maybe what's more mentioned in the EULAR guidelines, thinking about benefit on sleep. hopefully no one's thinking A or D. Well, E could be probably used. It may not be specific for the sleep benefit, but certainly could help pain and then help sleep, right? Just for completeness, very briefly, we wanted to just put in a few other nociplastic pain conditions. We talked a lot about fibromyalgia because that's what we have the most evidence for, but I did put in here a few other conditions and just some very brief considerations for each of them. When you look at all of them, you're going to see the heaviest weight is on the non-pharmacologic treatments that Diane was mentioning that do have a lot of pretty good, robust evidence. And then there's less evidence for many of them for medications. So irritable bowel syndrome, you see a lot of non-pharmacologic things. And yes, there are medications that can be helpful too, but really it's the focus on the non-pharmacologic. Similarly, with tension headache, there's a lot of robust evidence for a lot of non-pharmacologic treatments here. From the medication standpoint, we could look at things like NSAIDs and Tylenol potentially as needed. TCAs and SNRIs might be helpful for prevention. When you're thinking about the as needed medications, SNRIs and Tylenol, thinking about not overusing and creating medication overuse headache too is a consideration as well. And then looking at chronic low back pain, again, you see a similar theme. One thing to point out here is that recommendations for management of chronic low back pain actually specifically state to avoid opioids in this instance as well, similarly to what we were talking about with opioids for fibromyalgia and that whole actually making the symptoms worse over time. So for conclusions, hopefully you guys, everyone here is able to come away with knowing that nociplastic pain syndromes are caused by central sensitization, like we talked about. Really, we have to think about nociplastic pain as really central components to complex conditions. There's a lot more that goes into someone's diagnosis of fibromyalgia. And like Diane was mentioning, that fibromyalgia-ness or maybe nociplastic pain-ness, right? Like how much it affects you at different times or in different days of the week. Really management of this pain syndrome centers around the non-pharmacologic modalities first, and then adding in medications. They can help decrease the sensitization, but their evidence is not as robust as we would hope and as significant as we would hope as well. So, we have like 5 minutes for questions. Maybe we want to we do have the learning assessment questions in here for you all. We could just leave them there for you, but in the interest of time, if there are questions, we could go through questions. That's okay. What questions are there? If none, that's okay too, but we've got time. All right. Is that, yeah, if there aren't questions, then we can go through we'll just run through the learning assessment. So sorry, now you all saw the answer, but just for completeness. So first question here is nociplastic pain is pain from a sensitized nervous system, including amplified processing of pain, decreased inhibition of pain, or both. True. I gave you that answer if you were quick enough to see it, but yes, this is the definition of nociplastic pain. Which of these conditions would be considered a nociplastic pain condition? I'm seeing some and hearing some musings of C. So tension headache, exactly. Others, diabetic neuropathy would be neuropathic pain, and fracture, osteoarthritis, those would be maybe more nociceptive pain versus nociplastic pain. The Euler guidelines gave a strong 4 recommendation for which of the following non-pharmacologic interventions. Are you doing the YMCA? Or I saw some A's, yeah. Really, the strong 4 is for D, for aerobic strength and exercises. Are cognitive behavioral therapy and Tai Chi there? Yes, but really the one that has the strong 4 is exercise. And really, like Diane said, it's anything that you can do. Like, yes, aerobic would be the most preferred, and we know it has a lot of evidence, but certainly anything is better than nothing. Which of the following are not guideline recommendation medications for fibromyalgia per the EULAR? So this is select all that apply. We already did this one earlier. So B and E are the ones that are not specifically mentioned in the guidelines, although certainly we could use them. It's just not what's specifically mentioned. And then lastly, this is another patient case. So similar patient that we had, I think it is the exact same one. Actually, so I won't read through the whole thing for you, but thinking here, again, we reviewed this question. That's right. It's a similar question we had earlier. So which of the following would be the non-pharmacologic treatment you would recommend for our patient case? We talked about this earlier as well. So a walking regimen and hydrotherapy. The referral to chiropractor, like we were talking about, that actually has a strong against recommendation in the EULAR guidelines. And I hope that we are past recommending bed rest whenever possible. Interestingly, when you talk with patients sometimes that are in their older years, are more elderly veterans or patients in general, I feel like I hear patients saying, well, I'm just supposed to rest, or I'm not supposed to do things at all, because that used to be what we thought about, right? You think back on old medical literature and it talks about laying in bed for months on end, but that's clearly not helpful. And then this one we also reviewed as well. So that patient, what would we prescribe for sleep? And like I mentioned earlier, we were thinking cyclobenzaprine and amitriptyline would be the most correct answers. We could argue duloxetine, but with that, there's your most awaited CE code, and we're happy to answer questions if there are any. Yeah, like for what medications we would consider, you're saying? Yeah. Really the guidelines have the more recommendations for things like cyclobenzaprine and amitriptyline that would be our problems, right? Pregabalin would be a more potential higher option, or like gabapentinoid, pregabalin, gabapentin dose more towards the evening. The problem that I see, and I'll let you join in if you have other thoughts too, Diane, is that all of our medications for pain have a lot of side effect potential. And unfortunately, that's just the risk that we balance with everyone. When I do see those geriatric patients, though, I try to steer away from things like TCAs and cyclobenzaprine type agents if I can help it first, and targeting, maybe I would use something like a duloxetine first, even though it's not specific for sleep. If we get benefit on pain and maybe some additional benefit on that norepinephrine, serotonin balance and improved mood, you maybe sleep better because you just function better in the day. So it's kind of the down trickle effect. Can I say I don't use TCAs and cyclobenzaprine in geriatrics? No, but it's trying to be very cautious on the dose and monitoring.
And then it's also just treating the sleep disturbance as a separate issue as well. So referring them to the CBT for sleep, just traditional sleep aids, melatonin, targeting it from that aspect as opposed to just the pain.
Mhm.
Right. We'll stick around if anybody wants to come up and chat. Thanks.
Thanks.